Hello everyone, welcome to piyushmallick.com. This will be our first transesophageal echocardiography podcast regarding goal-directed therapy in difficult anesthesia cases and critical illness of ICU, which will also include some cases on regular basis of emergency medicine. So why in anesthesia we need this tool? Alright, I'll try to convince you that probably this is one of the best monitoring tool which has been missed out. In 76, Dr. Leon conceptualized this concept of transesophageal echocardiography or TEE. Now, this concept came to cardiac OT, operation theater of open heart surgery in 80s, and entry to non-cardiac theater and ICU, even in emergency department, is quite recent. So, is there any particular indication or guideline to use transesophageal echocardiography in anesthesia? Let us see what the guideline says. American College of Echocardiography and Society of Cardiovascular Anesthesia has recommended perioperative, preoperative and intraoperative use of TEE. They have recommended preoperatively any patient that is hemodynamically unstable, patient with no definite diagnosis of his instability. That means undifferentiated shock, thoracic aortic aneurysm or dissection, patient had a pulmonary embolism, or any unknown factors. You think that this is your differential diagnosis and you do not know why this patient has suddenly gone down. Preoperatively, you can see those and you can act upon. Intraoperatively, very clear cut, acute, persistent, or any kind of life-threatening hemodynamic disturbances started or it's anticipated, you can use transesophageal echocardiography. And it is obvious that people have been using for valve repair, congenital heart disease repair, repair of hypertrophic obstructive cardiomyopathy, endocarditis, aortic pathology, pericardial procedure, you name it. This is already there. The thing is, what I am trying to say, that use of TEE is going to change everybody's perspective, and probably in this presentation, I promise you, I will prove that this is the best monitoring tool you will have, or you have it. Now, newer evidence, transesophageal echocardiography, this is from emergency department. CPR, TE guided CPR can change your management to 180 degree. So both in diagnosis, monitoring, quality of CPR, giving fluids, giving vasopressors, everything. So why do we need that? We have so many things like pulmonary Swan Gang, PCWP or pulmonary capillary wedge pressure monitoring, CVP, pulse pressure variation, stroke volume variation, esophageal Doppler, lithium dilution technique, the LIDCO, pulse contour analysis, the Vigilio, IVC collapsibility by ultrasound. All these are there, right? Then why do we need that TE again? Now, let me tell you one point is there are so much of loopholes in everywhere. But pulmonary capillary wedge pressure, it was supposedly the gold standard. So all this calculation for other monitoring has been taken from there. Now the sepsis guideline itself says the pulmonary capillary wedge pressure doesn't work. Okay, there is no mortality benefit, and based upon that, CVP is was there, and it was calculated that CVP low, give fluid, Now, what if a patient is having a right-sided heart failure whose CVP is always 20? Would you give fluid? Would you not? So CVP is a static measurement, you know. So it has gone down. There is a lot of development not to go for CVP anymore. Has been there in literature. Probably CVP is not a good choice. Now I'm putting just 1 point each on this. Now pulse pressure variation, we know that 13% or 20% pulse pressure variation or more, patient needs fluid. But it is very difficult to know that which part of the Frank-Stanick curve you are keeping your patient. Now, everybody says drier is better. Even the kidney fellows are not flooding the patient with saline. I know previously used to say give 5 liters of fluid in sepsis. The things have changed. Fluid is probably as bad as anything. Like, it has to come out, it goes to interstitial, it produces a lot of badness. Same goes for stroke volume variation. So higher, we don't know exactly where to keep the fluid, right? Now, esophageal Doppler is probably a very good thing. Works as the same principle as TE, but thing is that you don't see the heart, right? Completely, all chambers are not seen. You presume that the flow is there. It's a dynamic monitor, probably better than anything, but you don't see the heart. Lidco, pulse contour analysis. These techniques, they themselves say that there might be 30% inaccuracy in case of extreme. If patient develop high blood pressure, there is a chance that 30% inaccuracy of the result or the values which is there, which will be improper. So, IVC collapsibility, again, in recent past, there has been a lot of challenges and a lot of talk going on against IVC. So, if what I'm saying is T is the best monitoring tool, then why don't we use it? Now, issue with anesthesia or emergency medicine or in ICU is this, that can you think of one thing, like, our best way of getting a difficult intubation, which was known, predicted difficult intubation or known difficult, is to do a awake fiber optic. There is no second thought about it. If it is awake fiber optic intubation, so how many in our undergraduate training has been trained? The most valuable technique is anybody? I have been not trained in my this thing, in my undergraduate days or sorry, post-graduation days in anesthesia. Now everybody knows if cannot intubate, cannot ventilate kind of situation, you do a surgical cricothyrotomy, right? Have you been trained in this? So this is the problem with our education system. The best thing comes after a lot of struggle. So TEE, transesophageal echocardiography, I am telling that this is the best monitoring tool we have. Then why don't we use it? Probably it is training, probably it is cost, probably it is act like PNDT which is stopping it, and probably a lot of other things which might be. But let's see that what TEE can do. We'll take some example of cases, and this is, as I said, it's not for ASA grade 1 or grade 2 patient. It is for those guys, those who are dealing with sicker patients, and those who want to really manage, interested in managing sicker guys in a lot of safety, on increasing safety. All right, let's go to the presentation pop-up. This is a TE probe. We will get to know in details with due course of time exactly in the real video. What is it? This is how it looks like. It has a knob, and this knob, if you rotate, this is after putting it left upper corner. If you see the picture, you just put the probe like a endoscopy probe or GI endoscope. You advance or you can withdraw. And this knob which we saw just before this picture, that if you rotate, it antiflexes and retroflexes, like left lower picture. And inside it, there is a knob. Inside it, you press the second knob. It's not a roundish knob. You press those, and there will be a rotation of the piezoelectric crystals direction from 0 degree to 100 degree. So you can see the heart, in a plane of whatever your requirement are. And this is from, you rotate the probe, it can rotate into left or right. All right. Now, how do you put the probe? Patient's neck to be extended. It's just like our intubation, and anesthesiologists are probably the best people to place it safely, because they do the intubation regularly. A lubricated TE probe has to be introduced in the midline with a zero, it would say unlocked probe. It should not be locked. The probe has to be advanced to esophagus. Now the era of video laryngoscope, especially the anesthesiologists, those who are doing it, this will be much safer. Exactly, you can avoid those trauma. There is 0.5% to 1% chances of esophageal trauma in this. So, which is quite less. It can be even lower by the hand of anesthesiologist. Cardiologist can produce more trauma. Okay. During this maneuver, the controller must be in neutral position to get it accommodated with the way it is going. All right. So this multiplane probe can see, we just spoke, the 0 degree to 180 degree, and at 3 basic levels, it can show us the finding. At the upper esophageal level, mid esophageal, and transgastric. So all these views, those who are, I'm going to tell you briefly, that this will be at the 3 primary levels. Now, good news is the NGT probe size has been decreased, and it's reduced to a size of, the TE probe size has been decreased to NGT size. You can see it here, the TE probe size, which is disposable. It's something like, 2 years back it was $500, and like this, it can be not only disposable, it is detachable. Suppose your patient is very sick and you need to go after operation for CT scan or some other, or going to shift it to some other centers, you can just leave this probe detached, and you can reconnect up to 72 hours and leave it there. So smaller size TE probe has less injuries, detachable, so flexibility of movements and all those things are there. Now, American Society of Cardiovascular Anesthesiologists has recommended 20 different views. Actually, if you think rationally, there are only 4 views. What are these? You can see here, transgastric, okay, transgastric 2-chamber, mid-esophageal views. So basically, it's boils down to 4 major views: mid-esophageal 4-chamber, superior vena cava at the mid-esophageal level, transgastric, mid and deep to calculate your cardiac output, and aortic view at the mid-esophageal level to know exactly what is happening to aortic flow and aorta proper. Why not conventional transthoracic echocardiography? These are its demerits. Suppose a patient is undergoing a thoracic procedure or upper abdominal procedure, or getting ventilated, so you don't get those views, and the standing where your examination would be from. So COPD, or the patient having inflated lung, so you don't get those proper view during the anesthesia or in kind of ICU, especially in transthoracic view. Patient would be transthoracic echo, especially in supine position in ICU. These are the some of the difficulties. So these are the advantages. Transducer is very close to heart, so you get a very clear picture, especially of the posterior structure of the heart. It is far away from surgical field, so it has got very high image quality. It better visualizes the left atrium, which is posterior, and mitral valve, left ventricle, pulmonary valve. Most of the things has been very clearly seen during TE examination. Now, biggest advantage of TE, you know what? It is the easiest one. No one can miss it. Even a novice, first time doing TE probe, anesthetist put the probe, he will get this. He will get this picture. Invariably, he will get this picture. You see, there are two kind of heart in this picture. This first is good heart, the same kind of contraction and same kind of very clear chambers. Look at what will happen. The next picture, all sludge. It's a failed heart. You can see exactly how the blood is flowing, what are the speed, how, I mean, so there are a lot of advantage. Just putting it, you get a fair idea about the heart. You saw that? All right. As I promised that we'll take the TE topic, why an anesthesiologist or a critical care fellow or an ED doctor should use it. A case number one. He was around 75, 76-year-old, was posted for total hip replacement. He arrested on table. This is a real case, all right? And arrested during the cement, halfway through the surgery, all right? It was a 9 minute of arrest. I'll have the pictures of arrested heart while they are doing or they were doing the CPR, and now we will go to those pictures. What happens after the when the heart was revived. Successful ROSC after CPR. Epinephrine was used for used 3 times, and TE was used during the arrest and in the ICU as well as during the SIPT. Okay. Now this particular case, what did the TE do? Would it have been a different management plan had it been otherwise? Let us see. Now this is after the ROSC was taken, ROSC came back, resuscitation, and there was a successful outcome of the survival. All right. What you are seeing, just look at the right side. Can you see some bubbles coming there? Left side looks okay, there is some calcific mitral valves. But right side, there are some bubbles you can see. This is after 30 minutes of revival from the arrested period. Okay. Now the same thing, when we take a pulmonary artery picture, you can see those bubbles. It is around 40 minutes. So what effectively you are seeing, that we stopped all the fluids thinking that this is air bubble, and this was not air. After stopping of those, everything that was going on, this was still visualized. So actually these were all cement or embolized or acrylic materials, those who were there, those who caused the arrest. And in that same period, we got a value of tricuspid valve regurgitation amount to know exactly what is happening to the pulmonary artery pressure. So to our understanding, if you see very carefully, the velocity and the pressure gradient was this 101, plus his CVP would be his pulmonary artery pressure. Got it? So pulmonary artery pressure was around 115 or 120 at that period of time. With the patient's blood pressure was around similar amount. So effectively, the pulmonary circulation blood pressure and the systemic circulation blood pressure was nearly the same. Now, at those transgastric level, what we saw, this is the right ventricle and this is the left ventricle as level. You see, left ventricle wall was kissing together. So there was nothing, no blood was coming to the left side. When you saw the right side ventricle, can you imagine how dilated it was? Okay. So it was a bone cement embolism event, and there was no flow to the right side, to the left side. It was kissing left ventricular wall. All right. So what do you think? What way TE helped in this case particularly? Did we change any management plan? Now, I will post that intra CPR TEE events later on, the next slide, but it did guide us during the CPR. Now, kissing ventricular wall, what does that mean? That means no fluid is coming to the left ventricle or no blood is returning from the left ventricle. Although there was a D-separated ventricle, the right side was pushing the left side more and more. So first of all, had it been more fluid, because he was hypotensive, and had it been more fluid given to the patient, there would be more dilatation of the right ventricle, pushing more the left ventricle towards inside. So more of a chance of hypotension with more fluid. So we restricted the fluid. So RV size was more than the LV size. So there was something grossly wrong, which a normal heart was going on. So usual knee-jerk reflex was to give fluid. So we did not give any fluid seeing this picture. All right. Now his pulmonary artery pressure was 120 and his blood pressure was 110, 120. So we that was, I mean, you would think that there will be no flow of pulmonary vascular resistance and systemic vascular resistance, or the pressures are the same. Okay, so if we can increase the systemic vascular resistance by some means, by norepinephrine, phenylephrine, dobutamine, milrinone, obviously we all know that norepinephrine is a good choice. Once the blood pressure is built up, left ventricle will behave or will have more resistance. So at least at that time there will be some forward flow of the pulmonary artery or pulmonary circulation to the left side. So this was it. To reverse the flow, we chose norepinephrine. So fluid versus pressure, which was more important? Obviously the pressure was more important. Now the best part is the pulmonary artery pressures were high and he was getting 100% oxygen with high PEEP and high tidal volume. All those things where knee-jerk reflexes ventilate hard and fast, and so those things were there. So once we saw his pulmonary artery pressure around more than 100, so we reduced his tidal volume, reduced his PEEP, managed with some kind of norepinephrine. So ultimately, eventually, everything, the cycle is broken and patients got better. So it guided the ventilation also, right? You were doing high PEEP, so pulmonary artery pressure is 100 or more than 120, and you are giving more PEEP. So it will be a mechanical additive factor to the pulmonary artery pressure, which was already high. So this is his cardiac arrest phase. This was a normal ultrasound machine. That nerve block ultrasound machine was connected to TE probe, and this is what we got during the compression. Now you see the compression is going on, all those fluids are pushed in, everything is seen, it looks nice, right? It looks nice. Now the surprising fact is, now you see this left side and right side, the same person is compressing. Now if you see the left side, it is a very bad compression. All right, same force is being applied. Once we told him to go up 2 centimeter to the north, I mean normal conventional way of compressing is to take the chief sternum and you start compressing. But TE can tell you exactly. You see the right side heart, especially here, is on the right side, is getting compressed well in the right picture. So it did help to compress. So probably the guide, everybody's heart is differently placed. We don't know what we are doing. So putting a TE probe, you can actually guide the quality of compression. So these are the two things to start with, that to have a thought, like, if this is the best monitor, then why aren't we using it? Thank you very much. I know that this is a thought-provoking thing. There are a lot of limitations getting TE, but this is what future of anesthesia and future of critical care is coming in a big way. Thank you very much.